Hello, sir. I'm audible, sir.
Yes, you are audible. Where are
So
we
sorry.
now?
Sorry for the technical issues. So he underwent FJ insertion on 38 2025.
Dr. Aslam,
Yes, sir.
may I interrupt you here?
Yes,
In
sir.
one breath, you said three sentences. So I just want to. You said. So why was that important?
Sir, your voice was breaking, sir.
Okay. You said NG was not inserted. Why is that important?
Sir, ideally, in case of a corrosive insertion, injury, we are not supposed to put Riles tube, sir. There is conflicting data, but majority says that ideally we should not insert a Riles tube because before attempting an endoscopy, sir, to see for the grade of the injury, because there is a chance of perforation, and if it is a not a complete injury, then there is a chance of stricture formation also, sir, if we keep a Riles tube.
So the simple answer here is NG should not be inserted. There is no two ways about that. Okay.
Yes,
For a
yes,
corrosive. Okay.
yes, sir.
Second, you said endoscopy was done after 24 hours.
Yes, sir.
So, what is your take on that? Should endoscopy be done after corrosive? Should it not be done? And if it is to be done, what is the ideal time for doing endoscopy in such scenario?
Sir, ideally endoscopy should be done within 24 to 48 hours, sir, and maximum up to 96 hours, and not between after that, sir. After 5 days, we should not attempt endoscopy because chance of perforation is there. Till 3 weeks, we should not attempt, sir. For 5 to 15 days, we absolutely contraindicated, sir.
So, what is your protocol? Do you do endoscopy in every patient who has a corrosive history of corrosive ingestion?
Yes, sir. Every corrosive injection we do, sir.
What is the idea of doing endoscopy in such scenario?
So, idea to do endoscopy is to stage the disease according to Zargar grading. If it is less than or equal to 2A, we start early oral feed, sir.
So it is more of a triage
Yes, sir. More of a triage investigation. It can predict also the chance of stricture rate. If it is more than or equal to grade 2B, then stricture formation is more than 50 to 70%, sir. And more than that, sir.
There is one school of thought which says that endoscopy should not be done after corrosive.
Yes, sir. Some school of thought says like CT can be a complementary to endoscopy, but
CT will discuss later. But
yes,
some people are hell bent against endoscopy, that endoscopy should not be done. So what is the fear?
Fear of perforation, sir. That endoscopy should be done with experienced endoscopist and with low insufflation, sir, so that the hospital stay, we can plan the further treatment accordingly, sir. It will help us rather than doing harm, sir.
So the endoscopy that is to be done in these patients is not a routine endoscopy that your first year, second year resident in gastro is going to do. So you have to give certain instructions to the person who is doing endoscopy, or they themselves will also know who is the experienced person. What are those instructions?
So instruction like we should do gently with low insufflation of air, sir.
That is okay, but what is the most important thing?
Hello, sir, your voice is breaking, sir. Able to hear.
What is the most important thing? Can you hear me?
Sir, I'm able to hear.
Low insufflation, gentle is okay, but what is the most important point?
We should not push the scope, sir, if we see any resistance.
Yeah, so no resistance. Once you find injury, you stop at the first sign of injury. That is the most important, because your idea is only to try it, not to do a full length endoscopy.
Yes, sir.
So you don't have to do a full length endoscopy. You stop at the first site you see some injury and you grade it and then you come back. So you don't have to do a full endoscopy. That is the most important thing. Okay.
Yes, yes, sir.
And then the next thing you said was about CT.
Yes, sir.
So what is the idea of doing CT in such scenario if you have already done an endoscopy?
Sir, endoscopy usually upgrade the disease, like overestimate the injury. And if CT also complement endoscopy, if you see Zarga grade 3B necrosis, and if the patient is clinically stable, if CT is showing no transmural necrosis or any periesophageal perforation, then we can actually wait the patient before taking up for surgery, and we need not to do emergency surgery, sir. So CT can complement endoscopy.
If you're doing both endoscopy and CT in a patient, why not just do CT and omit endoscopy then?
There is some school of thought to do CT, sir, but the majority like endoscopy is preferably better, sir. We can avoid CT also if it is more than 2A, sir. I mean less than 2A, we can avoid CT. Less than 3, we can avoid CT, sir. Radiation risk is also there.
So you don't want to do CT in all the patients?
Yes, sir. I don't want to do CT in all the patients.
Which patients you don't want to do a CT?
If it is a low grade injury, Zargar grade 3A or less, I don't want to do CT, sir.
Okay. So let's move on then.
Yes. So after that episode, he underwent FJ insertion after on POD on the injury day 3, and he was started on feeds on day 3 of surgery, which he tolerated well, and he was discharged after 15 days on FJ feeds, which he was taking around 1.5 liters per day. So he developed the complete dysphagia after discharge for around 1 week. That is almost 3 weeks after the intake of corrosive. And there was a history of loss of weight around 10 kilograms in the initial 1.5 months, followed by gain of weight around 5 kilograms after escalating FJ feeds till dates. And he underwent repeat endoscopic examination in the same center after around 2 months. He did not undergo any therapeutic procedure, and he was referred for our hospital for definitive management. No history of any pain abdomen during the stay, no history of any abdominal distension following that, or no history of any nausea, no history of any cough with expectoration, no history of any fever in the recent past, sir. Coming to the past history, no history of any previous surgery other than the feeding angiostomy procedure he underwent, no history of any psychiatric illness or any history of any suicidal attempt, no non-comorbidities. Past history, he was a non-smoker, non-alcoholic, sleep-wake pattern normal, normal bowel and bladder habits, and he was a lower middle class socioeconomic status. Coming to the summary, 22-year-old male from Bihar, ingested around 50 to 60 ml toilet cleaner with suicide intent, developed hematemesis, oral burning and hoarseness of voice, managed conservatively in ICU. Endoscopy was done at 24 hours, followed by CT scan. No rice tube was inserted. He underwent feeding angiostomy, and he progressed to complete dysphagia in 3 weeks. He had a loss of weight, followed by gain of weight, and the repeat endoscopy was done at 2 months, and he was referred to our department for further management. Coming to the examination.
Sam, let's hold on for a second.
Yes, sir.
You just finished a summary of the history.
Yes,
so
sir.
What do you make of it? What has happened really?
Patient had a corrosive injury, probably acid injury, because toilet cleaners was ingested, and but he was saying a Harpic blue color. He was taken, and after that he had a.
What is Harpic then?
Sir.
What is Harpic?
Harpic as a white and blue one, sir. Blue one is white is alkali. That blue one is acid, sir.
Sulfuric acid?
Sir, sulfuric acid.
So blue Harpic is sulfuric acid?
Hydrochloric acid. Hydrochloric acid.
Be sure of it, no?
Yes, hydrochloric acid.
Yeah, because Indian law doesn't permit
hydrochloric acid
or marketed in the for toilet cleaners.
Yes, sir.
Okay.
Yes,
so what else happened after that?
After that, he had a hematemesis, sir, and with hoarseness of voice, but he did not have any and burning sensation of mouth also, but he did not complain about respiratory distress, sir. So probably he had a luminal injury rather than a tracheobronchial or bronchial this thing, and laryngeal injuries. Mild edema, voice change was there, but no respiratory distress. So unlikely he would have aspirated, but he would have had a upper esophageal injury along with probably gastric injury, not sure. He had a hematemesis, so likely that he would have had a stomach injury.
So this patient is managed by one team somewhere, I don't know which team, but you agree with the management, or do you want to do something differently? Or would have you have done something differently at that point in time?
The patient, they have done early endoscopy followed by CT scan also, but right tube was not inserted. All those things were fine. But repeat, they could have done a early assessment for structure formation, probably with a barium study at 3 to 4 weeks, sir. And endoscopy could have been done at 4 to 6 weeks rather than 2 months. Otherwise, their management was more or less okay, sir.
Okay, why do you think a CT scan was done?
CT scan could have been done because he would have had a
Yeah.
higher grade injury.
In your history, anything pointing to the indication for a CT scan?
He had a hematemesis history, sir, and
Okay.
he immediately had a dysphagia and adenophagia also, and he had underwent a endoscopy followed by CT. So probably I think that endoscopy finding would have been more grades.
Oh, so anything in history which gives you indication for CT scan?
Hematemesis only, sir. Other than that, no.
The patient with hematemesis get a CT scan done?
No, sir. Otherwise, there was no chest pain, and there was no severe chest pain. There was no severe abdominal pain to go on towards any perforation. So history-wise, I could not find any absolute indication for CT scans.
And Bharti, anything?
That is perfectly fine.
Okay, I have a couple of comments to make regarding the history. I'm not sure. See, what happens is nowadays history is given to you as a separate slideshow. That may not happen in actual exams, and you have to describe your own history. Usually these histories are long, especially corrosive ones. So the better way to put it in the history of in the presenting complaint is patient had dysphagia, presented with dysphagia for so and so months following intake of corrosive, which happened around 6 months, 8 months back. And the next sentence about the history of persistent starts. History starts in August 25 when all this what you described happened. Often what happens is that sometimes these patients have undergone some kind of a surgical procedure to manage the complications, and some of the examiners may have a problem with putting that in the presenting his present history, and they may want that in the past history, because the present problem is actually the dysphagia, nothing to do with the hematemesis, hoarseness, ICU management, what bearing does that have now. So that is why it's useful to make a string of history so that nobody raises a finger on how you're presenting it. Second, obviously, Rajesh has already asked you these questions. These questions will crop up as to whether you do endoscopy, why you do endoscopies, and why, and which patients you do endoscopies in. The important thing is to know which patients not to do endoscopies in. That's one small bit is left uncovered. So, would you want to comment on that, Aslam,
Yes,
about which patients
the
you would not do
patient has
endoscopy?
oral cavity injury, which could our laryngeal injury, which compromise the respiratory thing, and then we will avoid, sir. As respiratory distress.
Just say respiratory distress. It could be because of several things. It may not be because of oral injury. Patient may have aspirated some acid. Okay, respiratory distress. What else?
Other
Not so difficult, is it?
uncooperative patient.
Uncooperative. Very good. That's
Or
very important. Actually.
Yes.
It's not unusual for the patient to be jumping around and you attempt endoscopy. Okay, what else?
And patient if
Not a difficult question. I thought it was a straightforward question. Suspicion of perforation,
no, sir.
severe chest pain, abdominal pain, tachycardia, 140, blood pressure 70.
Yes, sir.
No,
Yes, sir.
not difficult to answer, right?
Yes, sir.
These answers should be available in quick succession. Extremes of age, 2-year-old, 88-year-old. Be very careful in getting endoscopies if at all advising them. So that's where that question becomes important. Is there another way to manage this patient without endoscopy?
Yes, sir.
right? The point about endoscopy, how far should it be done? And so essentially, when you encounter scars, so which basically means 3A, 3B injury, you
Sir.
stop. Audible, not audible?
Sir, your voice is breaking. Not audible, sir. I was breaking in between.
Okay, so when you encounter severe injury, you stop. Not at the site of first injury, because first injury
Yes,
may
sir.
be actually a 2A injury. So that's the whole idea of getting endoscopy done. Now, the last bit
Yes,
of
sir.
why do you actually get endoscopy done? So you said
Yes.
triage. How does triage help you? What does triage mean?
So triage, like if it is a superficial ulceration, and then you can start oral feed early, and patient the hospital stay will be less, and the patient also will psychologically better, and in that patient you can actually discharge the patient early, sir. But whereas another patient, if it is higher grade, you have to admit the patient and watch for any complications, sir, and then their hospital stay and all those will be higher, sir. And probably if it is very high grade, we have to plan for further investigations like CT scan also.
Okay. Your answer is correct. Only thing is that endoscopy alone doesn't play a part in that. You don't, so patient has a grade 2A injury and is unable to swallow saliva, you're not going to push him to eat.
No, sir.
Okay. Patient's got a 2A injury and he's got a pulse rate of 150. Would you ask him to start swallowing?
No, sir.
Would you discharge him? So that's what I'm saying.
No, no.
Endoscopy is one of the cogs in the wheel.
Yes, sir.
So you can just say that, okay, it helps you in triaging a patient, but it is not the
Not
only
like-
feature.
Yes, sir. Yes.
A lot of other features play a role, okay. But rest of the answer is perfectly all right. So attempts at early oral intake and early discharge, and requirements of ICU stay, and requirements of further investigations if so. But
Yes.
again, caveat is that endoscopy alone doesn't carry much weight unless it's corroborated by other clinical features. Okay, there will be patients.
Sir, you-
Endoscopy alone doesn't carry weight unless it is corroborated by other clinical features. There
yes,
are
sir. Sure.
a number
Yes,
of patients who come to you now after 6 months, and you look at the history, they actually had a grade 3A or 3B injury, but they never
Yes.
went to the ICU. They never got a CT scan done,
Yes, sir.
right? So it's not
Yes.
that all of those patients will end up in the ICU, all of the patients require a CT scan.
Yes,
That
sir.
is why that is one of the features you use to triage the patient further on. Okay,
Yes,
let's go to the examination.
On examination finding, the patient was averagely built but poorly nourished, well hydrated. Height was around 164, weight was around 48 kilo, BMS of 17.9. There was no pallor icterus, no pedal edema, no generalized lymphadenopathy. Pulse rate was 60, regular. BP was around 90-60 millimeter mercury. ECG status of 1. The thousand time of 32 seconds. There was no hesitation marks seen on the hands, forearm. Coming to the oral cavity examination, there was no oral cavity ulcers, normal tongue movement, adequate mouth opening. There was no tooth staining. Mucosa was normal. There was no normal voice also while taking history. And chest examination, trachea was in midline. Adequate chest expansion bilaterally. On auscultation, normal vesicular breath sounds bilaterally. No added sounds. No neck was normal. No scars were visible. There is no thyroid enlargement. Per abdomen wise, on inspection, abdomen was scaphoid. Previous feeding jejunectomy, midline scar, supraumbilical around 5 centimeter. FJ tube was in situ in the left lumbar region. There was no visible peristalsis in the abdomen. Hernial orifice was normal. Extensinator was normal. Coming to the palpation, no hepatosplenomegaly, no lump was palpable. Hernial orifice, there was no cough impulse. Extensinator was normal. Spine was appears normal. Coming to the percussion, liver spine was normal, around 13 centimeter measured in the right midclavicular line, measured starting from the fifth intercostal space. There was no shifting dullness. Auscultation normal, bowel sounds were heard. Rectal examination was normal. Rest of the systemic examination was normal. So coming to the provisional diagnosis, probably it could be a corrosive esophageal stricture, status feeding jejunectomy with grade 6 dysphagias. The voice was not.
Your history remains where it is. History and examination summary remains where it is, except it's got grade 6 dysphagia now. Am I audible?
Hi, sir. Now audible, sir.
Okay. So the history and examination findings remain the same. Your summary is the same exactly. Any new features added after the examination?
Examination wise, his BMI was on lower side, sir. He had poorly nourished. His supraclavicular hollowing was there. There was loss of buccal pad of fat, and there was mild temporal muscle wasting also. So he was nutritionally, clinical examination, his nutrition was on lower side. Build was adequate, and otherwise performance status was good, and even respiratory function, breath holding time was good, sir. Otherwise, other examination-wise, scaphoid abdomen was there. Other than that, no new added finding I could appreciate. Rest of the examination was normal.
Okay. Anything to add, Kamal Bharti, Dr. Rajesh?
No, sir, it is perfectly fine. Nothing left.
Rajesh, you're on?
Yes, sir. Yes, sir.
Okay.
Okay, sir.
Dr. Aslam, what next?
Next, the patient has come to us almost after almost six months, sir, now. So I already patient has grade 6 dysphagia and not been able to swallow saliva. So I would like to get a repeat endoscopy done, sir. And I would like to know the previous investigation also, if you had underwent early endoscopy at 24 hours. So if that reports are there and really CT reports are there, I would like to know about that process.
Dr. Aslam,
Yes, sir.
is it more important to investigate right now or do something else? You said that the patient is nutritionally poor.
Sir, I want to build up. I want to look into the basic blood parameters, sir. To look into the hemoglobin and albumin values.
Do you actually need to look at those parameters to
No,
suggest
sir.
something to the patient?
No, sir. No, sir. Not required. I want to. I can straight away start and get a nutritional opinion and
First of all, you have to take detailed nutritional history. How is the patient taking FJ?
Yes,
Is he
sir.
taking milk? How much water he is adding to the milk? How much calories is he getting? That is the should be a first assessment, because
Yes,
whatever surgical repair you are going to do, the results are going to depend on the nutritional status of the patient.
yes, sir. He was
So for
initial few days he was taking only liquid, only juice kind of thing. So he lost 10 kilograms. After that, proper nutrition chart was given to the patient, and he started mixing all the normal diet in the mixie, and calorie intake was almost 1,600 kilocalories, sir.
so,
And
so
and
what is your goal for the nutrition in these patients? Like, what do you want to achieve? When will you say that now the patient has achieved the goal and now you can go ahead with the further management?
usually the corrosive patients, we may not be able to attain normal BMI as normal patients, sir. But weight after the intake, and if patient has a weight gain of more than 5 kilogram, and patient ECG status is fine and other parameters are okay, and then after 3 to 6 months the patient performance status is good, then probably we can take up, sir.
What about lab parameters which you are looking at? What are the optimal lab parameters that you're looking at before you go in for surgery?
Sir, I want a hemoglobin of more than 10 preferably, and albumin of more than 4, sir.
More
And
than
there
4, I
should,
don't know.
sir.
I'm yet to see people more than 4, but okay.
Okay, Dr. Aslam, you wanted the earlier investigations. Do we have the initial endoscopy available? Can we click on that?
Endoscopy 23/8, 25 probably done on the day. Pharynx superficial ulceration was seen. Esophagus edematous erythematous mucosa with the deep ulcerations. Zargar 2B. Stomach extensive deep ulceration with necrosis. Zargar grade 3B is seen.
So you were the physician managing the patient at this point, 24 hours following injury. What would you do?
First of all, I hope the patient vitals are normal. Then patient vital is now stable and there is no history of any severe chest pain. Anyway, I will like to go ahead with a CT scan, abdomen, thorax, and neck, sir.
Why do you need a CT scan?
So showing stomach extensive deep ulceration with extensive necrosis, sir. So I would like to see for
What are you looking for?
see for
On the CT scan.
gastric necrosis levels, sir. I want to see whether it is a transmural necrosis with any perforation, early perforation. And
You're interested in the necrosis or the perforation?
perforation.
Necrosis, endoscopy is already telling you necrosis, no?
Endoscopy, some involvement. So might be able to get a CT can complement the endoscopy.
You see, all these patients, number one, they belong to a poor socioeconomic status. And number
Yes.
two, often they are also having a lot of issues which need to be managed, including nutrition, hemodynamics. So
Yes.
getting CT scan done is not all that easy,
Yes.
right? So you would want to triage the patient very carefully about CT scan requirement and the yield of CT scan. Otherwise, you'll end up getting a lot of unnecessary CT scans done in the acute phase. So getting a CT scan for Zerger 3B is based on what?
Voice was speaking.
Am I audible?
Sir.
Aslam, am I audible?
Your voice is breaking, sir.
You're audible. Maybe the problem is at their end, sir.
Voice.
I think so. I think that problem is at the GU punch end. Your net is not working very well because I thought mine was bad, but now I realize that probably it's your end that's the fault.
Yes.
Doesn't matter. So, what our question was, Zerger 3B grade.
Yes, sir.
The CT scan is required based on what information? Why do you need a CT scan? Patient is fine, he's got a pulse rate of 90, he doesn't have any pain abdomen apart from the usual dull aching pain.
So
No fever.
to wait till the patient, we may not have the adequate time for surgery also, sir. So to have a early decision making, probably CT would help, sir. But
No, I'm still lost. The patient is stable, pulse rate is all right, no fever, not much pain. Mild pain obviously is there. He's got dysphagia because he's unable to swallow saliva. It's 24 hours that this endoscopy is available. What is the indication for the CT scan?
then probably we can wait also, sir, like in the resource limited
You have
setting.
to stick to one side now. You can't keep on flipping and flopping.
Sir,
Single
I
is
would
right, this side.
actually, for Zerger grade B, I would like to do a CT if it is available and the patient is affordable because I want to see for any transmural involvement so I can anticipate any complication because the perforation may not manifest immediately. Clinical signs.
3B is the transmural involvement, no?
Yes, sir, but endoscopy sometimes overestimate the disease and it may not be able to tell if it is a transmural because we are seeing only the mucosa.
Okay, for a minute, I agree with you. The endoscopy says 3B, the CT scan agrees there's transmural necrosis. What have you gained?
If there is a transmural necrosis with if there is a perforation, then only we take for surgery, sir. Otherwise, we'll closely observe and keep patient in ICU. And
So then why the CT scan?
Yes, sir, I got your answer.
So the CT scan need was based on the data, I think surgical data, which said that patients with grade 2B or 3, or rather 3A, 3B injuries, the incidence of perforation found despite the patient having no clinical features to the tune of almost 25%. That is what it was based on.
Yes.
The problem is having that information and using information can be a different thing.
Yes.
You may get a CT scan done for Zerger 3B on endoscopy and not add anything. Remember, you'll give IV contrast as well. You want to give
Yes.
oral contrast?
No, sir.
Why not? You want looking for perforation, right?
Sir, if it is because the patient is at high risk of aspiration, so if we give
Yes,
oral
so he's
gastrectomy,
already having dysphagia and has got a high risk for aspiration, so no
Aspiration.
oral contrast.
yes, sir.
Okay. Right. Rajesh, anything more or we move forward?
Let's move, sir.
Okay. So that was endoscopy, you got that. So you want a CT. Yes. Was the CT done at that point?
It was done, sir. Like according to patient history, it was done.
Do we have that available with us?
Probably not, sir. Like it's not mentioned.
Okay. So we don't have the CT scan. I assume that patient was not operated after the CT scan, so no major findings aside from what endoscopy showed you.
Yes, sir.
Okay. So now the patient is with you. Now what?
Now, sir, I can. Patients having absolute grade 6 dysphagia, so I'd like to do a repeat endoscopy, sir.
We want to do endoscopy.
Yes, sir.
Okay. Um,
Your endoscopist is not going to do the endoscopy before you give them something else also.
So we can attempt a barium study, sir.
Can attempt or should attempt?
We should attempt, sir.
Because your endoscopist is going to ask you that I need some roadmap because this is corrosive patient.
Yes, sir.
Aslam, that is the problem is that patient having absolute dysphagia
Yes, sir.
often can't swallow much.
Yes, sir.
And often when you give barium to them, they will aspirate.
Yes, sir.
In fact, you'll get a call from the radiologist when you send the patient down.
Yes,
The
sir.
patient is asking you absolute dysphagia. Do you want me to do a barium?
No, sir. Thin barium, we can attempt thin barium, but, preferably.
So unless the patient is able to swallow some saliva, barium is not a very good idea. Of course, endoscopy always needs a roadmap.
Yes, sir. Our protocol is to do early an endoscopy, and after endoscopy to do a barium, and then repeat endoscopy if any therapeutic procedure is planned.
Okay. So this is the finding on endoscopy.
So this was a repeat endoscopy after coming when he was presented in our institute. There was a smooth circumferential stricture seen at or just below the upper esophageal sphincter. Scope or guide work was not negotiable.
So tell me something. The patient had hoarseness to begin with.
Yes, sir.
So getting endoscopy without getting any other assessment, is it a good idea?
ENT examination of your ENT examination of the teleideal should have been done, and oral cavity examination should have been done early.
So either you can separate the evaluation of the laryngeal inlet, which means the ENT does it first and then endoscopy does endoscopy, or you can combine the two
Yes,
by
sir.
what is known as hypopharyngoscopy,
Yes, sir.
wherein you evaluate both the laryngeal inlet as well as the pharynx and upper esophagus.
Yes, sir.
But often in most institutions, the two examinations are done separately.
Yes, sir.
But doing endoscopy and not having any information about the laryngeal inlet is a bad idea,
Yes.
especially in patients who have a high stricture.
Yes, sir.
Okay, so this is the information available. What do you want to do next?
So I would like to see for a ENT evaluation of teleidal examination. So I would like to do.
So why do you want to do ENT examination now?
I would like to the evaluation of the other any hypopharyngeal adhesions or this thing, an epiglottis, any adhesion or any
But
laryngeal.
how is it going to matter if your scope has been negotiated through that and it has already reached till upper sphincter? If you are able to do endoscopy, that means the upper channel is patent.
Yes, sir.
So what more do you want to achieve by doing that?
I would like to know whether the vocal cord mobility is adequate and whether the patient.
As sir said, that should have been done earlier, before
Yes, sir. Earlier.
endoscopy. But now you've already done endoscopy, patient has uneventful procedure, and now the injury is not very high.
Yes, sir.
So now I don't see much role of an ENT now here. I fully agree that it should have been done before endoscopy just to rule out that there is involvement of the higher.
Yes, sir.
Okay, so what do you want to do next?
So this is a high stricture, sir, and very.
How do you define high stricture?
Sir, high stricture is either within 14 to 16 centimeter or within the 1 centimeter of upper esophageal sphincter, sir.
I just missed your initial definition. Can you
Sir,
repeat?
either it is within, endoscopically within 14 to 16 centimeter from upper incisor, or at just, within 1 centimeter of upper esophageal sphincter, sir, just below hypopharynx.
So, what was the finding in this endoscopy that suggests that it is high stricture?
So, in this was a stricture seen at upper esophageal sphincter, sir, like just at or just below the upper esophageal sphincter.
So that is the watershed point, na, upper esophageal sphincter. If anything is above, then there is pharyngeal involvement. That is the high stricture. Anything below the sphincter is low. So why do you call it high stricture?
Because there is no the anastomosis in this case, we should be attempting at the like lower hypopharynx rather than esophagus, sir. So this would mostly will go in high stricture rather than low strictures.
So why do you need to separate high stricture from low stricture?
Sir,
Why do you need to separate high stricture from low stricture?
high stricture.
What is the difference in management that is useful to you?
Sir, high stricture probably like risk of aspiration is high, and probably if not done in the lower hypopharynx, then need for tracheostomy, and we might have additions if there is the additions under the ENT involvement also is critical in the management, sir. They might have to do adductolosis also if some additions are present in the hypopharynx, and surgical success also relatively less in hypopharynx, and it's complex surgeries rather than low stricture where it is usually straightforward.
What is surgical success?
Improvement of the dysphagia and need for further dilatation, sir.
No, so for example, this patient is a high stricture?
Yes, sir.
Okay. So why would you have stricture? You said dysphagia following bypass or whatever reconstruction you want to do. Why is surgery difficult?
Actually, it is closer to the laryngeal inlet. Surgery technically is not, more than surgery, so the patient outcome is not good because patient is the anastomosis near the laryngeal inlet and the risk of aspiration is high, and the angulation is also little laterally rather than vertical course. So
that's why I wanted to ask you this question. You just brushed it away saying surgical success is lower. What does surgical success mean? Patient outcome is poorer. That
outcome is poor, sir. Yes, sir.
But anything different you do surgically? For example, anastomosis in the lower neck or cervical esophagus versus pharyngeal anastomosis. Anything different you do surgically?
We have to open the lateral pharyngotomy as to be done posteriorly.
So in the cervical esophagus, you do it anteriorly?
No, sir, that also posteriorly.
What is the difference?
So oblique incision.
Sorry?
No, it's difference. We might need tracheostomy, sir, if it is above the laryngeal inlet.
Okay, so essentially when you're doing in the pharynx, you are interested in positioning it below the laryngeal inlet.
Yes, sir.
Or as you just defined, lower hypopharynx.
Yes, sir.
So that is the only difference between the two. Aside from that?
Apart from that, the gastric conduit may not be possible all the time because length may not be adequate. So sometimes if colonic pull-up may be preferred, the gastric length is not adequate.
You mean for the higher rather than the lower?
Yes, sir.
Okay. A normal stomach will reach the base of tongue. My boss used to teach me this. So why do you say that it will not reach the hypopharynx but will reach the cervical esophagus?
If length is adequate, then spines are otherwise.
Okay, let's move forward then. So what do you want to do next?
So that Next, I would like to counsel the patient for surgery, sir, and take consent for surgery.
What consent do you want? He says, I'm having dysphagia. You do what you need to do. What consent? What specific thing in consent do you want to ask him?
We have to explain the need for colonic pull-up if stomach is not normal, and we have to explain that it's a mobile surgery. We would can have a mortality of less than 5%, and there we will not be resecting the native esophagus, and we will be diverting, and we require multiple anastomosis, and there could be chance of anastomotic leak also. And patient, we have to explain about prolonged hospital stay and need for ICU care, and plus or minus if intraop we are not able to do a lower down anastomosis, then we might have to do need for a tracheostomy also. The tracheostomy most probably will be able to decannulate in more than 75% in this case, but you might have a need for a permanent tracheostomy also if not able to take orally, like later on he had issues, and even if it is a lower chance, then we have to explain about the chance of any conduit issues like anastomotic leak or any fistula or any necrosis, and very rare chances. And then we have to explain about recurrent nerve injury, very unlikely, still we have to explain him. And chance of pneumonia, ventilatory support also we have to explain.
In a pharyngeal anastomosis, why would you damage the recurrent laryngeal nerve?
We usually don't damage the like only thing by doing
What surgery are you planning?
colonic pull-up or gastric pull-ups, depending upon the stomach anatomy.
So resect the esophagus and replace.
No, sir, we don't resect the esophagus.
So if you're not resecting the esophagus, then where does the recurrent laryngeal nerve come in your field?
It won't come, sir. Very unlikely if inexperienced surgeon while dissecting the neck, while they're seeing for the esophagus.
Okay, fair enough. So, right. So this is the patient now.
Yes,
So
sir.
next what? Consent given. Now what?
Now I will plan for surgery, sir, like colonic pull-up or gastric.
Nothing else in between? No other evaluation required?
Would you like to do a CT abdomen, CT angiography of abdomen, colonoscopy?
Sir, this young patient, our protocol is not to do any colonoscopy or CT abdomen. And for looking for the status of the stomach or lower esophagus, some centers do CT and do retrograde dilatation from the opposite side, but not able to cannulate. But if in our center, if adequate is a lower hypopharynx intact, then we straight away go ahead with surgery. So we don't do CT scans. Only in old age, more than 50 years, to rule out any diverticular disease or any atherosclerosis, we do so.
You are doing a CT scan for what purpose? I am a little lost because you said a lot of things. If you do a CT scan, what is the purpose? To look at the native esophagus?
Yes, sir. Actually, in some centers, they have mentioned, like in Narayan study in Jibmar, they have found that in high upper esophageal sphincter, if you're not able to pass a Gedvar or this thing, to see for the neck esophagus in CT, and then open on the right side and try for a retrograde dilatation rather than going a hypopharyngeal anastomosis. And to assess the, so that was one thing, sir, but in our center, we usually don't do that. And then we can assess the stomach status also in CT. We can preemptively assess if stomach is normal, we can plan, but intraoperatively we can assess anytime.
So the patient has absolute dysphagia. The stomach will be normal?
Sir?
Patient has absolute dysphagia on the CT scan. How do you assess the stomach?
May not be possible, sir. The stomach will be contracted.
Don't just keep on completing a list. No, you have to have some practical bearing on what you're saying.
Yes, sir.
You come from a high volume center, you should be able to justify why you need a CT scan at all.
We don't.
You said something about retrograde dilatation, fair enough. But a patient where the stricture is at the upper esophageal sphincter and the hypopharynx is available, you need a CT scan of the
No,
neck?
sir. No, we don't. We don't do CT scan.
So if you're not doing, then say that it's not to be done. Our approach is the same. We don't do a CT, but you
Yes.
can get this question in exam.
Yes, sir.
Then you have to answer whatever your institute is doing, and there has to be some reason why the institute has been doing. You have been
Yes.
doing colonic pull-ups. Did you have any problem in any young patient?
No, sir.
Were
No,
you
sir.
were you not able to do a colonic pull-up in a young patient because of some vascular? And
No, sir. No,
even if
sir.
there is some vascular anomaly, you find ways to deal with
Yes, sir.
intraoperatively.
Sir.
And that is a very rare situation. That is why you don't need to do a CT
Yes, sir.
angiography of colon in these patients.
Yes, sir.
But you have to be confident. Na? You just cannot say, okay, we are not doing, but someone can do. Then you are saying that we are doing something wrong.
Yes, sir.
You have to defend what you are doing if there is a logic and science behind it. No?
Yes. Yes, sir.
Okay, you saw something about colonoscopy? Yes, no. Why not? Why yes?
No colonoscopy, sir, because in Engage we don't do colonoscopy, sir.
Why?
Because colonoscopy may only aim is to do rule out diverticular disease. It's very uncommon in our Indian scenario. In Engage it is not. I mean, very less, sir.
So you're looking for polyps and diverticular disease. Both are diseases usually of the older age. But it is not that patients do not have polyps in the younger age in India.
Yes, sir.
We have sufficient documentation now. The only problem is that in a patient who does not have any history of colonic disease, which means no history of bleeding PR
Yes, sir.
and no other history of constipation, diarrhea, IBS-like symptoms, the yield of the colonoscopy is going to be very, very low in a patient who's 20-year-old.
Yes, sir.
That's the rationale we use for not getting a colonoscopy done. If I do just twist the scenario, same scenario, and this patient gives you a history of some bleeding PR in the past, would you
Yes,
do a
sir.
colonoscopy?
If it is single episode, then we may not do, sir. If it is a persistent chronic disease, then we will do, sir. Otherwise, no.
So essentially, then you are looking for a source of that rectal bleed.
Yes, sir.
If the patient has grade 2, grade 3 hemorrhoids, you'll be satisfied.
Actually, ideally, if it is a long-term bleed, then preferably to do a full-length colonoscopy, sir.
Muslim, that is what we were just pointing out. Don't be dogmatic and sit on your stand that my institution doesn't do this, we'll never do it. Your institution is actually following a policy with a protocol.
Yes, sir.
Those caveats are often missed to you. You
Yes,
don't
sir.
realize that there is a lot of caveats behind that approach.
Yes, sir. Yes.
Patients often come to you with some laparotomy done in the past. You don't even know what procedure is done. You want to evaluate more before doing a colonic pull-up.
Yes, sir. Then we have to do, sir.
That's what I'm telling you. So don't be so dogmatic that we never do it, I'll never do it.
Yes, sir.
Okay?
Yes,
And
sir.
be aware of the rationale being used by the institution as to why, if you don't do it as a routine policy, it is always the routine policy that you don't do it. It's not
Yes,
that
sir.
it's never to be done.
Nice, sir.
Okay. Anything else you require in this patient before? So no CT scan, no colonoscopy, and you're happy. So let's post him tomorrow.
Nutritionally, he was already like tried to optimize, sir, in outside hospital. So we have admitted, and so we also have tried to optimize the nutrition. And BMI is close to 18. So albumin is normal. Now there is no pedal edema. We can do, sir, colonic pull-up. Already 6 months is over. Initially from the intake.
Post surgery, patient has psychosis. So what have you missed?
No, psychiatric referral we should have taken, sir. Like.
So always get a psychiatric referral. In an occasional patient, maybe not in all patients, you will get stuck because you omitted looking at anything beyond the esophagus and the stomach and the colon. And the post-op, even despite having successful reconstruction, patient doesn't swallow.
Yeah, sir.
Because he's having a psychiatric breakdown now.
Yes, sir.
There is another thing that you are forgetting. What is your likely procedure going to be in this patient?
Probably colonic pull-up, sir.
Because stomach had grade 3B injury, na?
Sir, yes.
So it's likely to be scarred. So what
Yes.
else do you do if you are doing a colonic pull-up?
We have to start give colonic preparation. We have to give, sir.
So you have to prepare the colon also, no?
Yes, sir.
Yes, sir.
Yes, sir.
But you have to prepare the colon also, no?
Yes, sir.
Otherwise,
The other
it
thing,
is going to be unaesthetic surgery.
Yes, sir.
the
Sir,
other thing is, all these patients, you should always get a pulmonary assessment done.
pulmonary.
And yes, you
Yes.
should always be talking about in a formal fashion. I need a pulmonary assessment, whether that means only a chest X-ray and a physiotherapy and an incentive spirometry, or whether it means getting a PFT done and
Yes.
IDL done. That can be tailored to the given patient. But you
Yes.
should always convey that I'm aware that lungs may not be entirely normal and they need assessment.
Yes, sir. X-ray test is mandatory, sir.
You're not doing anything, right? That's why you ask those questions. You want to post the patient tomorrow without getting anything done, which is a very dangerous proposition.
Yes.
Correct. Dr. Nag, what do you do beyond this? Do you ask questions from the students?
Sir, if there are some questions, then we can answer. We can check on the chat.
I'm not sure that there are so many questions. If there are any, do they have a voice or are they?
They have voice. Anybody wants, participant can ask question from the moderators. There are few students, but we have not muted anybody. Everybody is active from both sides.
Okay, I think so. Broadly, we are done. Dr. Aslam, beyond this, if you go, you will probably be asked some questions about colonic pull-up as to how do you choose which part of the colon, pros and cons of left or right or mid coloplasty, and
Yes,
then troubleshooting during coloplasty, lengths of the colon to be chosen, and so on and so forth. So there are several directions the Viva can take from here onwards.